welcome everybody. It's fantastic to see so many people lined up. There's quite a bit of work that went into this meeting, and I would just like to introduce myself. I'm Michael Schulz. I'm a professor of gastroenterology at the University of Otago in Dunedin, New Zealand. And we had summer until yesterday, I guess. Yesterday lunchtime, suddenly it changed. So we went from 27 degrees down to 17, and then overnight down to 8 degrees. So that was a bit of a sudden, but hey, that happens. Yeah, together with Chris here, who you all know, he doesn't need any introduction, and he's online somewhere. I think it's many people at the moment. So together with Chris, we talked about how to make this monthly meeting a little bit more attractive and how to give it a little bit more structure. So really what we thought, and Mei Ling obviously had a big say in all of that. The structure should be just following the anatomy. So the structure should be starting at the esophagus and just walking our way down, esophagus, stomach, duodenum, small intestine, large intestine, and branch out left and right. And you might want to wonder what's Steve doing tonight with hepatitis. Well, simply we didn't have a speaker lined up for tonight, and the liver is kind of somewhere between the mouth and the anus. So we thought, yeah, why not having Steve to talk, and then we can get even better organized next week. So what would be really fantastic if you guys can participate and contribute. I mean, these meetings are, I think, run best if there is an incentive or reason to be here. So if you got any cases, if you got anything interesting, then please let us know. It would be fantastic to have registrars or junior doctors or even students or whatever talk about an interesting case they had over the last week or last couple of weeks or so, and we can kind of do our presentation along those cases. I think that would be absolutely amazing. So I will, over the next week or two, I will publish the curriculum on the Viber app, and if you just let me know or Mei Ling know or anyone know what you can contribute, that would be cool. And we then obviously try to find a speaker that has a little bit of a clue about the area that we're talking about. And I think this could be actually a quite fantastic meeting. It can be covering everything from educational over peer support over a little bit of review. Have I done everything right, or was there anything I could have done differently? So really take the opportunity to use this forum as a valuable source of research and as a valuable source of people, like-minded people who would like to kind of just be involved or get involved. So as I said, in about 4 weeks' time, we should start somewhere at the esophagus, and it's not decided yet whether the esophagus is malignancies or the motility disorders or just reflux or hiatus hernia or anything like that. So I think we can decide all that down the line, what we want to do there. So that's the starting point. I think what we should do now is have Steve talking. Steve joined the University of Otago probably about, Steve, was it 5 years ago or 6 years ago or thereabouts? 7 years ago. Oh, sorry. Yeah. So 7 years ago. And what became immediately apparent is that Steve is a fantastic teacher. He really manages to bring across these complex topics in quite a very good way so that everybody understands it. And certainly, I mean, until Steve joined, I hated liver. I still kind of do to a certain degree, but he made it so much easier. And I saw him teaching today, and he was teaching 4th year and 5th year medical students. And I think what I really appreciate in Steve is that he comes down to basics. What's really important for you guys that you're starting your career? I don't talk to you about all these fancy hepatology things, but I talk to you about what's really important. And that's why I thought Steve would be a good first speaker, because we all get bombarded with liver cases, and I certainly don't, as I said before, I have my difficulties with liver cases, but you've got surgeons who talk to you about liver cases because suddenly they looked at the liver function of whoever is on their ward, and liver function is abnormal. What do we do? You have obstetrics and gynecology with liver cases. You have obviously your gastroenterology colleagues. So I think it's a good topic for basically everybody to get a little bit more familiar with liver. So I think without further ado, Steve, do you want to take over? And of course, guys, if you have any questions, if you have any cases, if you want to discuss anything, I think Steve will talk for maybe half an hour or so, you said, Steve, or a bit longer.
It's quite longer.
Yeah, okay. There will be time at the end, or interrupt Steve, or whatever you do. This should be interactive. So this is for you, and see if you want to contribute to that. So Steve, over to you, please.
Okay, well, thank you for that introduction. In your honor, I've relaunched this this title to Liver Disease 101, Approach to Liver Disease Somewhere Between the Mouth and Anus. Michael, is that showing up okay on full screen? I can't tell on my end.
Well, you need to click the full screen icon down there, and then it's perfect.
Okay, how about that?
Yep.
All right,
we're there.
Okay, so here we are. It is somewhere between the mouth and anus, and I traditionally I have an interest in liver disease, but I find liver talks to be extremely boring, and they just sort of all morph into strange little lab tests or biochemical things. So this is a bit more practical, and I designed this test this talk because when I first started taking care of liver patients as a resident, I hated liver patients, and I couldn't really figure out why, because they were just very complicated and difficult to really pin down. And over the years, I began to enjoy it, and I realized I enjoyed it because I've kind of organized it. So I'm going to share with you guys how I look at liver disease, and then we're going to talk about the most common liver disease on the planet and give you some very practical things you can use in the clinic or in the hospital, and it's not theoretical stuff. So I also like to call this hepatology for dummies, because that's the way I kind of look at things. Yeah, so we'll launch into that. So at the end of this talk, what we're really looking for is I want the audience to recognize how to recognize serious liver disease. Some real world basics. I love basic talks because it reminds me of things I used to know I might have forgotten. So this is very basic talk. And also to be able to accurately classify the broad categories of liver disease and use a framework that will help you sort of organize these people and make you less anxious, or makes me less anxious in taking care of these people. And then we're going to talk about the most common liver disease on the planet, which is fatty liver disease, which I find horribly boring, but there's some really interesting tidbits you can use in your clinic that are worth the price of the admission. So here we go. So when you're dealing with somebody with liver disease, the first question that I had as a student was, well, who do I put in the hospital? Is this an emergency? Do I need to call for a friend? Is this friend grumpy? Is it too late to call somebody? Am I going to catch this? So these are some really basic things that I think we should all think about. And so get to the first thing, who needs to come into the hospital? Well, with liver disease, it's kind of like anything else. If they're just too sick to go home, the volume depleted, they have lots of illnesses. If they're encephalopathic and it's new, that's a big red flag, and they should come into the hospital. If they don't have social support, you can't maintain close follow-up, you think you're going to discharge them and they're going to just disappear, you probably just keep them. Toxin-related liver injury is one you probably ought to keep. And if you're just not sure what's going on, it's probably worth keeping them in the hospital at least overnight. So the way I like to define liver disease, like I just call everything hepatic dysfunction, because it covers everything, and you're never wrong, and it's really vague, and that makes life simpler. So the way I look at it is I say, well, you got hepatic dysfunction, it's either acute or chronic. And if it's in a chronic liver disease, Basically, it divides into either you have cirrhosis or you don't. If you don't have cirrhosis and you have chronic liver disease, you have one of these diseases: fatty liver disease, Hep C, Hep B, hemochromatosis, and the list goes on and on. If you have cirrhosis, the first thing you should always think about, this person's going to get a liver cancer. Hepatocellular carcinoma is huge in this population, and that's what sort of takes out most of my patients anyway. So that's one thing to always think about first when you see a patient with that diagnosis. If they're cirrhotic, then you got to subclassify. You got to say, well, do they have portal hypertension or not? And if they don't have portal hypertension, or you can't tell, you say it's compensated cirrhosis. If they do have portal hypertension and it's not bad, you might still have compensated cirrhosis, but you have portal hypertension. And if you have portal hypertension, you might have one of these things like bleeding varices, encephalopathy, ascites, hepatopulmonary, hepatorenal. Then you are by definition a decompensated cirrhotic. And that's a big deal. And we're going to get to that a little bit more. So how about the acute hepatic dysfunction? This is a little easier, and also they're a little bit more scary. So if you have liver failure, that's quite scary because these people do terrible. And you need to enlist the help of a liver transplant services if you have access to one. And liver failure is going to be defined as loss of synthetic function and hepatic encephalopathy. You have to have both those things. And if you have both those things, by definition, you are in liver failure. If you have preserved synthetic function, that'd be things like acute hepatitis A or hepatitis B, ischemic hepatitis, a lot of those things. So that's really the big picture of how I look at liver disease, because almost any disease will fall somewhere in this big tree. But just don't forget that non-cirrhotic can become cirrhosis. Acute can turn into chronic. No portal hypertension can turn into portal hypertension. And preserved synthetic function can turn into liver failure. So it's just the great big wheel of fun liver disease that keeps us on our toes. So I mentioned decompensated liver disease. This is a big deal. And if you're talking to one of your colleagues about it, a patient with cirrhosis, if you throw decompensated cirrhosis in there early, then communication's a lot more clear. You'll know you're dealing with somebody who has a variceal hemorrhage, ascites, SBP, cancer, hepatorenal, hepatopulmonary, or hepatic encephalopathy. So that's a big deal. Why is it such an important point to make clear to everybody taking care of that patient? Well, because if you have compensated cirrhosis, you're going to live a long time, more likely. If you're a decompensated cirrhotic, the mean survival is 2 years. But honestly, that's pretty optimistic. I don't seem to do as well with that as these data would suggest. So how about fulminant hepatic failure? This is the most dramatic and the scariest one of all, as any doctor is going to face. They have rapid onset of liver injury, and they have liver failure, which again, we're going to define as hepatic encephalopathy and a coagulation issue, such as elevation of PTINR. And you can subdivide this. It doesn't really matter a whole lot in practical terms, but hyperacute is less than 7 days, and they get cerebral edema, and they actually kind of do a little bit better. Acute, 7 to 21 days. They all seem to get brain swelling. And subacute, they usually die of renal failure and portal hypertension. I just attended the AASLD liver meeting in Washington, D.C., and this was the topic they talked on and on about: acute on chronic hepatic dysfunction. About 80% of the talks were about this, and basically it just means somebody who has chronic liver disease, now they're falling apart. And it might be now they're encephalopathic, they're worsening synthetic function, they're bleeding, renal failure. But the main point of all these talks and all this discussion at the meeting was you need to find that event that precipitated that acute on chronic hepatic dysfunction. And it might be infection, medication, any of those things listed. And the more of the decompensating characteristics, such as hepatic encephalopathy and varices, The more of those things you have, the worse you do. Well, that's pretty intuitive. So what do you do for these people? So here you are all by your lonesome in some remote island in the Pacific, and you have somebody with acute hepatic dysfunction. Most of the time, all you have is supportive care. And it just depends on how much supportive care you have in your center. If you have access to an ICU or transplant center, that's the gold standard. You know, that's great, but you may not. So you're going to think about just the usual good medicine things, such as repleting volume, give them crystalloid, albumin, blood, fix electrolyte problems, give them a little oxygen, give them some nutrition. Don't let them fall and bust their head open. If they have a coagulopathy, give them a little vitamin K to just rule that out. Consider giving some thiamine. Avoid taking out their kidneys with nephrotoxic drugs, and wash your hands, because these people get infected right and left. So what else do you need to do on these people? Well, you kind of need to decide early, is this a plumbing problem or is this something else? And if it's a plumbing problem, you'll find that out on an ultrasound. You're looking for dilated ducts. Also, you can look for a vascular supply problem. So if you got a Doppler or an ultrasound there anyway, might as well do a Doppler study and see if they have portal vein thrombosis or hepatic vein thrombosis. You don't have a lot of tricks in your bag to do something specific. If they're a paracetamol overdose, you got N-acetylcysteine, which everybody is very familiar with. If you're not sure if they've been exposed to paracetamol and they're in pulmonary hepatic failure, nobody will fault you for going ahead and giving it. And there's even some data to suggest that N-acetylcysteine and non-paracetamol overdoses might have some benefit. So if you're in doubt, just go ahead and start it. Steroids might be helpful, but that's a little bit dicey, and this one you might want to think real hard about. It's usually going to be beneficial for alcoholic hepatitis or autoimmune. If they got acute fulminant hep B, then you think about an antiviral such as entecavir. If they got acute hep A, hep E, or hep C, you got nothing. You can be nice to them and supportive. That's all you got. And then just think about the weird things such as HSV, Wilson, that kind of stuff. All right, so let's get into the most common liver disease on the planet, and we'll start this with a case. So Mr. T is a 51-year-old man with a little hypertension, hypercholesterolemia. He's got a little bit of a belly on him, diet-controlled diabetes. He's coming in for follow-up. He's on those meds. He drinks a couple beers about 3 nights a week. Family history is not terribly exciting. He works at a manufacturing company. His exam is not too exciting. He's overweight for sure. BMI of 29.8, and his blood pressure is a little on the high side. His ALT is 35, AST is 28, so it's not scary. Glycolated hemoglobin's up a bit. Last year he had an AST of 43, an ALT of 44, and that resolved when you told him to quit drinking so much. So which of these statements are true? And this is when I wish I had an audience I could see people's response to these things. So this man's risk for fatty liver disease is approximately 60%. Well, that's true. If fatty liver disease is present, his risk for NASH, non-alcoholic steatohepatitis, is over 60%. Ooh, that's pretty awful high, but it's true. And if he has fatty liver disease, his risk for advanced fibrosis is over 10%, which sounds pretty awful also. That's also true. So if we're going to be all in vogue and be cool on the ward, we want to maybe watch our language, because the old NAFLD, non-alcoholic fatty liver disease, is on its way out. And now the cool kids, the cool doctors are going to say, you have MAFLD. And that's metabolic associated fatty liver disease. It's all semantics, but that seems to be the trend right now with this disease. So let's get to the real basics. What do you need to make a diagnosis of fatty liver disease in this patient? So do you need a liver biopsy? Do you need imaging, elevated transaminases, and fatty liver on imaging? Do you need chronically elevated transaminases and a characteristic liver biopsy? Well, turns out you need imaging, and that's it. So does this man have fatty liver disease? Yeah, probably. But what can you do to establish that diagnosis in this individual? Well, you can do an ultrasound, you can do a CT, MR, or a biopsy, and that'll pretty much establish the diagnosis. So to get that diagnosis, you need evidence of hepatic steatosis either by imaging or biopsy, and it's usually greater than 5% steatosis, and the absence of other things such as alcoholism or medications, TPN, Wilson disease, Ray's syndrome, HELP, mono, all sorts of things. Now, I will also say this slide has also now become somewhat obsolete because at the meeting I just attended, they're kind of allowing the diagnosis of fatty liver disease and other things, which is a bit of a shift. So watch this space. This will probably be not as accurate right now. There's a lot of flux in what the diagnosis, how you make the diagnosis. But that's really all you need is imaging and absence of other things, kind of, period. So ultrasound's pretty good. Sensitivity 85%, specificity 94%. It's not bad. MR is rapidly evolving. It's pretty expensive and it's hard to get. We don't even do the proton density fat fraction in Dunedin. So it's not real common. CT is not as accurate as MR, but it's not terrible. How about scores and biomarkers? Well, they're not bad. The main problem with them, oh my gosh, if you can do that, then you are impressive and you should probably be teaching calculus somewhere. The NAFLD liver fat score is also kind of complex, but there's all these calculators online, so they're pretty helpful for that. So just quickly, there can't have a liver without a slide. So there's fatty liver without NASH. There's fatty liver with NASH. There's fibrosis, and there's our friend cirrhosis. All the liver cells are little collagen boxes. So they did a study in the UK, and they found that NAFLD was the most common cause of incidental LFT abnormalities of 26.4%, and of almost 7% or almost 8% of those had advanced fibrosis. And that's important. We're going to talk a little bit more about advanced fibrosis, about your prognosis. So don't forget about all those who have NAFLD and normal liver tests. So there's probably way more of those people. And if you don't, in medical school, they say, well, look to your right, look to your left. One of you guys is leaving or failing out. Well, look around you. One of before you has fatty liver disease. So the global prevalence of NAFLD is about a quarter. So about a quarter of the human population has fatty liver disease. So if you're going to know one liver disease, I know this one. If you don't know one more, I know Hep B, and that'll cover half the population of the whole planet. So this is what I was taught of how you get fatty liver disease. You're a couch potato, you eat the really good stuff, and you got fatty liver disease, then you roll the dice, and you might get cirrhosis and you might not. And that person not only got cirrhosis, but they got hepatocellular carcinoma. And that's what I grew up with, and that's the way I thought about it for many, many years. Well, it's not quite that simple. Here's another way of looking at it, where all these different things cause fatty liver disease, which will result in NASH, and it might be the environment, genetics, microbiome, metabolic syndrome, or you might even skip the fatty and go straight to NASH by any of these mechanisms. Here's one other way of looking at it, where everything feeds into a metabolic syndrome and visceral obesity, which leads to fatty liver disease, and then the NASH. This is a screen to make you want to go blind, because these are all the different definitions of metabolic syndrome. So depending on where you live, take your pick of how you want to define it, but it can be defined lots of different ways. It's just very common. But basically it involves BMI, waist to hip ratio, insulin resistance, fasting glucose, elevated triglycerides, hypertension, and low HDL. Lifestyle is huge in all this. So the high calorie, excess saturated fats, the really good food is the high fructose stuff, the soft drinks and such are very tightly associated with obesity and NAFLD. The sedentary lifestyle just makes it worse. Gut dysbiosis is going to be an important part of all this. And this is just one slide out of quite a number. I had an original talk about this, but I eventually, I think someday we'll be prescribing, probiotics for fatty liver disease. So I did mention fibrosis has a huge component in determining a patient's prognosis. And just remember, fibrosis brought on, it's pretty complicated, stellate cells, hepatocytes, all sorts of immune cells. But if you have early fibrosis, what's going to kill you? Well, your heart, you're going to have a stroke or heart attack. If you have advanced fibrosis, your liver's probably going to kill you. So there's that. So if you have stage 1, your mortality rate's not that bad. You look at that graph at the bottom, you can see stage 1 fibrosis, not too bad. Stage 2, not so great. Number 3, no. Stage 4, that's cirrhosis. You're not going to be around too long. All right, so I told you this would be a practical talk, and I want something you can take with you to use in your clinic or in the hospital. So here's a practical point. How would you counsel a male patient who has biopsy-proven NASH with stage 1 fibrosis about alcohol? You say, hey, dude, never drink again. Hey, you can have a little bit of wine, just don't drink too much. Oh, you can have a little bit of beer, just don't drink too much. Or, just don't drink at all. And you probably won't have fibrosis. Kind of A and D are kind of the same almost. So what's right? And what I used to always tell patients was, A, don't drink. Turns out a little bit of wine is good for not only the soul, but it's good for your liver. So what you say, I used to tell people you can't drink again. Well, as long as you keep alcohol below the risk threshold, which is about 30 grams a day for men and 20 grams a day for female, it might even be protective if it's wine. If they're cirrhotic, absolutely there is no safe amount of alcohol, 0, zip, none, nada. So moderate wine drinking is associated with protection from fibrosis, not beer and not binge drinking. So if you're a beer drinker, tough luck. Coffee consumption, so I think I'm going to be protected from that. And statins and renin-angiotensin aldosterone axis modulators may also be helpful. So yeah, you can tell your patients with stage 1, stage 2 fibrosis, yeah, you can drink. Probably, if you're going to drink a little wine, just don't drink more than you're supposed to. So should we screen for this disease since a quarter of the world's population has it? Well, nope, it's not cost effective. There's too many people have it. And how about we just screen the big people or people with known metabolic syndrome? Well, then it's controversial. So you can kind of pick the team you like and do it or not. Just depends. Depends on who you look at. The Americans, the Europeans, or more in Asia. It's all just different. So what do you do for it? And this again, where I used to really have a problem with, okay, I'm supposed to tell you to lose weight and diet and exercise. Well, that's kind of, I can tell patients that all day long and they're not going to do anything other than stare at me and go back and do what they're doing. So you need something very specific. And also you probably ought to evaluate them a little bit more once you identify them. So you can look at surrogate markers, and there's quite a few of these. They're easy to calculate. There's lots of calculators out there. And if you find they're at risk for fibrosis, you might want to think about a FibroScan if you can get one. But the markers are pretty good. So if they have the metabolic syndrome, okay, we want a structured lifestyle modification program. Well, that tells you nothing. That doesn't help you one bit. Optimal management diabetes, okay, well, that's just medical management. Structured weight loss program, well, again, that's not very specific to tell somebody. It's not very satisfying. And then comprehensive cardiovascular disease workup. Well, what does that mean? Do they all get a treadmill? Or, it's again not real helpful. So what is helpful is you say you need to reduce your caloric intake by 25%. And that's what, if you have access to a dietitian, they can help dial that in. So 25% reduction in calories. Again, that's a little tough because I don't count calories myself, and it'd be hard for me to reduce it by 25%. But what you can do is you can say, hey, let's weigh you right now and multiply that times 0.07. That's how many pounds you need to lose, or how many kilos you need to lose. So 7 to 10% weight loss will improve your histology and your labs and your prognosis. So what I always do is I give them a target weight. I say, this is the weight we're shooting for. And I write it down, I give it to them, and I say, that's the weight. And if they're motivated, they'll take that to heart. What about exercise? Well, it's hard to tell people exactly what to do because everybody's going to be different. But I tell patients that you need to do something 3 to 4 times per week for about 20 to 30 minutes. That's going to get you breathing kind of hard and your heart rate up a bit. So it might be walking uphill, might be riding your bike, swimming, whatever it might be. And you do that 3 to 4 times a week, and it'll make a huge impact in your health. If somebody just wants to lift weights, that actually works quite well too. So it doesn't have to be aerobic. And then the 25% reduction in calories is really helpful. Reducing fructose is key here. And that's where we get into the Mediterranean diet, which is this. And I'm not a big proponent of telling patients a particular type of diet because there's so many trendy diets out there. This one's been around a while and it's easy for them to get information on. You can Google it, get all sorts of very accurate information. But basically, it's just a diet high in fruits, vegetables, whole grains, nuts, seeds, olive oil, moderate wine consumption, fish, poultry, that kind of stuff. So that's what I recommend to my patients. And they all recognize that name and they can get information on it. And the dietitian can help them also. How about drugs? Is there any drugs you need to memorize? No, if they have diabetes, you're going to treat that aggressively, but nothing is approved for use. Metformin's been talked about, but it doesn't do anything. Thiaglitazones, no, they don't really do anything other than they make your feet swell. There's all these other things. None of them are helpful. They do little bits of lab changes, but just don't really, nothing's ready for prime time. Bariatric surgery does work. And if you have access to that and somebody who meets criteria for that, that might be their salvation to get the weight off, and that will absolutely improve their liver disease. And clears up the NASH in 85%. So that's the practical stuff I tell people. And that's all I got to say. I'm happy to answer any questions. I'll stop screen share.
Steve, fantastic. Thank you so much. Certainly helped me. And every time I hear you talking about the same topic, it does help. Now, we've got 35 participants now, which is really fantastic, Steve. Any questions out there? Anything that Steve is able to answer? Shoot away. Somebody is talking, but I'm not sure if they're talking to us. I can't hardly hear them. Let me ask you a question, Steve. So I talked to one of these big shots in liver disease, and he basically said, you're not going to die of your fatty liver disease. You're more likely to die of everything else, like cardiovascular risk factors. You're going to die of a stroke or a heart attack or something like that. What do you do with your patients in that regard if they kind of come to you pretty virgin without many drugs on board? Are you going to start them on a statin? Are you going to start them on an aspirin? Are you going to refer them to a cardiologist? What do you do?
If you catch these people early on before they have fibrosis or anything dramatic, I just have that conversation with them where I say, you know, this is what's going to kill you in the next 10 years if we don't do something about this. And then I make sure that they're having their cholesterol managed actively. Usually the GPs will do that. If their blood pressure is elevated, then they need that aggressively treated. But I do have that conversation with them that, you know, this is the stuff that's you're gonna die from if we don't do something. Once they get the fibrosis, then it becomes more likely they're going to die of their liver disease. They're going to be our patients on our service for quite a while. But yeah, and that's really when you work well. If you work well with your GPs and your primary care physicians, that's really helpful, because then you can feed back to the GP, hey, I'm really worried about this person. You know, think about, does this guy need a cardiovascular workup? Do they need a treadmill? Do they need aspirin? And they were actually quite receptive about that.
Okay. All right. Anyone else with any questions? Well, I've got another one to fire away here. It's good to have you here, Steve. So you didn't really make much of liver biopsies in your talk, and I think they fell a bit to the wayside. Is that because you're not ordering them very much, or is that because they're useless, or what would be a scenario where you would take a liver biopsy, where you would request a liver biopsy?
I've been kind of anti-liver biopsy for most of my career. A long time ago, the big recommendation was everybody with Hep C gets a biopsy. And my point was, why? It's not going to change anything. And if you have a diagnosis of fatty liver disease with imaging or abnormal liver function test or a combo package, what's the biopsy going to do to help you? If you're just trying to determine if they have fibrosis, there's other ways of doing that. So the only time I do biopsies nowadays is if I'm suspicious there's a different disease or a concomitant disease going on. Maybe they got hemochromatosis also, or they have autoimmune component to their disease. Those people all need biopsies. But you know, you have about 1 in 5,000 chance of dying from a liver biopsy, so that's one lottery I don't want to play if I can avoid it.
Okay. I just carry on with my questions that I have. Are you going to follow these people up? Are you follow you said fatty liver disease or MAFLD is kind of the coming epidemic. Are you follow them up, or are you handing them back to the primary care provider? I mean, it depends, I guess, very much on the health system that you're working in, but is that more a primary care problem then, once you've made the diagnosis, laid out a treatment plan, which consists of, well, don't get me wrong, but nothing more than just lose some weight and eat stuff that you would normally not eat and drink stuff that you would normally not drink. So is there anything that you follow up on?
Well, I think, and it's even controversial within our own department who should follow up. So it's not an easy question to answer. And I think the ones I would keep under watch and keep coming back to me periodically would be the ones either with advanced fibrosis, or if their LFTs are impressively elevated and I really think they got aggressive disease, I'll keep a closer eye on those people. If it's like this patient we just reviewed, or this one in the talk, I probably turn that person back over to his GP and say, you know, this is the advice, because this guy's still more likely to show up with a heart attack than cirrhosis.
Okay.
But I do it selectively.
Okay. I've got a fantastic question here. So are you checking the liver enzymes on a regular basis, and which ones would you check, and how often would you check them, or is that not telling you very much, the liver enzymes?
They actually aren't telling you much of anything. If they were, I typically will monitor them once to twice a year, depending on the level of the disease or the sort of my suspicion about the disease. And I usually recommend to the GP, I check the LFTs a couple times a year, once a year. But they'll fool you. They'll be normal, and they still have, NASH going on, so they're not terribly helpful. I guess if you the only reason I recommend doing it is if you see a big change in them, you might say, well, this disease is sort of taken off, or he's got a secondary disease. So yeah, not real often.
Okay, cool. Vikash, you got a question. Fire away.
Sorry, Dr. Michael. It's Tracy, his wife. I have a patient who's been diagnosed with fatty liver disease, and he's always having this chronic pain. I just wanted to ask, does fatty liver disease cause this? Because when we did the MRI, I sent the images to one of the radiologists in Australia, and he said that the pain could just be from the stretching of the capsule by steatosis and his hepatomegaly. I just wanted to know if you've had cases as such, and how do you manage? Because I'm having difficulty trying to manage his pain. Excellent question, Steve. You're the expert.
Yeah, that's a really good question. It's a really hard one to answer because I have several patients with the same thing where they have fatty liver disease, they have hepatomegaly, and they have this chronic right upper quadrant pain. And then is it from that, or is it neurogenic pain or something unrelated to the liver? And I don't believe that chronic hepatomegaly causes pain unless your liver is going down into your knees. It's just not going to cause pain. Now, acute hepatomegaly hurts. If you get acute hepatitis, it will hurt. And those people often, they've had their gallbladders taken out because somebody thinks they have cholecystitis. So I'm very skeptical if somebody's saying that pain is related to their fatty liver disease, that's a chronic stable problem. If they got a whole bunch of amiodarone or TPN and suddenly their liver's twice its size, yeah, that'll hurt. But I think you're probably dealing with non-fatty liver disease related pain. It's just chronic pain of something else.
Okay. On that note, Steve, what painkillers are safe in liver disease? I mean, you hear patients, yeah, I know, that's why I'm asking the question. You hear patients who come back to us and say, GP says I'm not allowed to take paracetamol because it's not good for my liver. But then we have these end-stage liver disease patients admitted to the service who have been gobbling down whatever their codeine and they're half asleep when they arrive at the liver service. So what's safe to give them for maybe even non-liver related pain, because these people have pain for other reasons?
Paracetamol is very safe. The only time that's dangerous is if they're an active alcoholic and they're going to be depleted in their glutathione, and that's going to be run into that metabolic pathway. If they're cirrhotic, it's still safe to give them paracetamol. You just don't want to give them more than 2 grams a day. So I'm still a fan of paracetamol. If they just have fibrosis, they can take up to 4 grams a day. I really think if you give somebody narcotics for chronic pain, you're just setting them up for more problems of addiction and dependence. So paracetamol is fine. NSAIDs, I can't say that they're wrong. I just say so many people with bleeding duodenal ulcers, that's not the first thing I recommend, but ibuprofen is pretty darn safe, so that'd probably be okay too.
Any difference between ibuprofen and Celebrex, for instance, in terms of liver disease?
Not that I'm aware of. I think Celebrex, the main problem with that one is increased cardiovascular risk of MI. Yeah.
Okay, fantastic. 8:45 in New Zealand. I know with other guys it's much earlier. If there are no more burning questions or anything that we can clarify, what I didn't say early on is that after a couple of years of trying very hard, Steve has signed up for Enskita as well. And Steve, you're going to be training in country in the Solomon Islands, or where are you going to go?
I'm going to the Solomon Islands in September.
Yes, so that's fantastic to have you on board, and yeah, the people of the Solomon Islands can be glad to have you there. And yeah, if there are no further questions, as I said before, welcome to this new format and the new date and hopefully a curriculum. So by hopefully the end of next week, I have the curriculum published on Viber. And I think Chris already volunteered for the 30th of March, which is the next Pacific Gut Club. And he's looking for volunteers. It's about esophageal motility, I think, Chris, if I'm not mistaken. So if you got any cool cases or any complex, difficult cases that has something to do with esophageal motility, would be fantastic to get in contact with Chris or with me or with Frank or anyone so we can link you up. Thank you so much for coming.